Professor Thomas, I'm going to ask you next about some aspects of your early involvement with issues relating to non-A, non-B hepatitis and hepatitis C. So if we could go first of all, please, Shamik, to RLIT 301242. And you'll see, Professor Thomas, this is unresolved problems in haemophilia. And if we go to page 3, we can see that these are the proceedings of an international symposium held in Glasgow in September 1980. And you were one of a number of speakers and attendees. If we can then go to... Sorry, just find the page. I think it's page 33, Shamik. We can see this is a short paper authored by you, Dr. Bamber, Dr. Kernoff, Clinical, Immunological and Histological Aspects of Non-A, Non-B Hepatitis in Haemophiliacs. I may come back to a couple of your publications around this time in a little while, but we can see this is the paper presented at the symposium. But what I want to do is take you to the discussion that followed the presentation of the paper, and we can pick that up at page 42. We can see a question being posed by Professor Stewart about active hepatitis and the questions posed in particular what happens in the haemophiliac. And then we can see your answer, and you say this: the lesion of chronic active hepatitis is a progressive lesion, and one would in a proportion of these patients expect an element of fibrosis and ultimately cirrhosis. None of our patients has had cirrhosis, but then if we are to believe that this illness at the most has been going on since 1974, when the commercial concentrates were first introduced, then this period is short in the course of the disease. There are some indications that these patients may have lesions which will turn to fibrosis or cirrhosis. And then you set out various observations and measurements. And then if we pick it up in the last 6 lines of this page, you say it's really now a question of how long. Just because we've not seen it in this 6-year period, it does not mean that it will not happen. I think the thinking is that it takes 10 or 20 years or even 30 years for these lesions to progress. I think we have to realise that these are young patients with many years ahead when we're considering the significance of these lesions. And then you go on to contrast that with the situation in relation to chronic persistent hepatitis, which would have a much better prognosis. And just I'll ask you first of all whether, no, I'll kind of put it this way. What you appear to be saying here, if I can paraphrase, and if you can assist with whether this is correct or not, is although you are not currently seeing levels of cirrhosis in the patients who you were concerned with and who you'd been studying, your suggestion here was that was not because that was not going to be a problem in the future, but simply a reflection of the progressive nature of the disease. And your expectation was that there would be problems with chronic active hepatitis, fibrosis and cirrhosis in the future for this cohort of patients. Is that a correct understanding of the message you were giving here?
Yes, I think that's spot on, really. I mean, it was one of the reasons for doing biopsies, because we knew, by analogy with chronic hepatitis B, that if you saw chronic persistent hepatitis, where the inflammatory cells were in the portal tracts and not going into the rest of the liver, then this was essentially a benign condition. Whereas if you saw, as the name implies, chronic active hepatitis, then this the liver cells in and around the portal tracts would be destroyed and would be replaced by fibrous tissue, which ultimately would result in nodule formation and bands of fibrous tissue, which we call cirrhosis. So, and the initial biopsies suggested that chronic persistent hepatitis predominated, and that chronic active hepatitis then occurred, and that then went on to cirrhosis. And I tried to demonstrate what the current thinking was at any point in time by Sheila Sherlock's book, which I think you mentioned somewhere else. So I presented to the Penrose inquiry, which showed that in one particular edition she was saying, and she is the doyen of liver disease, dead now of course, which at one stage, in one edition, the earliest edition, I think 74 or something like that, she was saying, this is a mild condition and we don't have to worry too much. And then in the next edition, when these biopsies had come through, she said, chronic active hepatitis, this is likely to be progressive. So yes, you're completely correct that the presence of chronic active hepatitis was a bad prognostic sign. And as with hepatitis B, this develops over decades rather than months or years or small numbers of years.
And then just to pick up the next, two papers on from this, Professor Preston and others' paper, it's page 45, please, Seamus, of this. So this is a paper presented by Professor Preston, Dr. Trigger, Dr. Underwood. And again, if we go to the discussion, it starts on page 50. But I wanted to pick up your contributions, which begin on page 51. And we look at the bottom half of the page. You say this, picking it up, I think 3 lines into your observations. I would suggest that we're at a stage now where we've got an idea of the sorts of lesions that we are seeing. A significant proportion, perhaps 40 or 50%, have chronic active hepatitis. And then there's a reference to the analogies with hepatitis B. You say it's much more likely that this form, since it's presumed to be caused by a virus, will be more closely analogous to the hepatitis B form of chronic active hepatitis. And then if we just go to the bottom of the page, you then refer to an alternative approach of observing patients for longer. And then you say this: we are studying the patients fairly early on, perhaps 2 years or so at the maximum after onset of illness, and we are not seeing much in the way of fibrosis, whereas Dr. Trigger is studying it perhaps a few years further on, and he has got a significant incidence of cirrhosis, so it may be a progressive lesion. And then in the next paragraph, you give a further reason for feeling that this may be progressive. And then you say, third paragraph, one can predict that there will be problems in the future. And then you pose the question, should there be trials being done, or do you follow the patients for longer? And then if I can just, before I ask you to comment, go to page 58. Bottom of the page. You say this in the last 4 lines: as Dr. Trigger has said, it's in 10 years' time that we shall see the problems, bearing in mind the proportion of the patients that are infected or have persistent abnormal liver function tests, anything from 60 to 80%. It will be an enormous problem when it happens. Again, could you just assist us with what your concerns were when you said that it will be an enormous problem when it happens?
Well, because a large number of patients, both with coagulation abnormalities like haemophilia, and also the substantial number of people who we thought were out there who had been infected because of blood or blood transfusions. This cohort, and we guesstimated, and by we I mean the epidemiology community and the Health Protection England guys and girls, they were predicting that there were probably about 150 to 200,000 people with chronic hepatitis C out there, and if this was progressing, then we were going to end up with quite a lot of people with cirrhosis. And I knew that cirrhosis, as did David Trigger, had a significant mortality. And in fact, the percentage with cirrhosis, I always remember it by saying every 10 years there's another 10% who have cirrhosis. So, when some of the young people in there, for instance, there was a hemoplasmapheresis cohort in Germany who got infected because of infected plasma. When that group of people, who were several hundred, I think, would work through them, up to 20-30% would have cirrhosis, and a significant number of those, as I've said, are 2 to 3% per year at risk of liver cell cancer, and something I haven't mentioned yet, 2 to 3% per year die of liver failure and require the only treatment for that is liver transplantation. So add all those things up, and it looks like a big problem on the horizon. Not to mention the problem from the patient's point of view, because the cirrhosis is not a pleasant condition.
So that's September 1980, that symposium, and then I wanted to just ask you a little about a paper that you and others published in 1981. Shomik, that's RLIT 40497. So this is a paper which I think we haven't looked at yet within an inquiry hearing. It's ultra-structural features in chronic non-A, non-B hepatitis, a controlled blind study. And we can see from the bottom of the page, it was accepted for publication August 27th, 1981, and it's published in the Journal of Medical Virology in the course of 1981. And if we can just go up to the top of the page again. We can see what the study entailed. Liver biopsies from 12 patients with chronic non-A, non-B hepatitis, 7 with hepatitis B surface antigen, positive chronic liver disease, 1 positive hepatitis B positive normal carrier, and 4 patients with non-viral liver disease were examined by electron microscopy for cytoplasmic and nuclear changes. And then if we look at the introduction, just a little further down, you and your fellow authors say there that following the development of diagnostic serological tests for hepatitis A and B infection, it became apparent that there were additional unknown viruses causing hepatitis in man, and these have been named the non-A, non-B group. So that's the background. If we can go over the page. I'm going to ask you about the first patient group that you describe under the heading patients and methods. You say 3 patient groups were studied, and the first is those with non-A, non-B chronic liver disease. Before I do that, if we just look at the top of the page, just so that we can understand the purpose of this study and this paper, which is about ultrastructural features. There's reference there to ultrastructural alterations being described in chimpanzees infected with serum from patients with non-A, non-B hepatitis. What was the particular purpose of the blind controlled study that you were undertaking here?
Well, all patients really that came in with unexplained transaminase elevation in Dame Sheila Sherlock's unit would have a biopsy early on in the management to decide several things. Obviously, we would do serological tests to diagnose hepatitis A and B without going to the extent which carried risk to the patient as well as to a lot of inpatient care before going to a biopsy, which would tell us exactly whether this was acute or chronic disease. Because you may have noticed that in haemophiliac patients with factor VIII concentrates, the transaminases go up and down, and they will have periods of normal transaminases, and then a week or so later, the transaminase will go up. And these patients came in with significant liver test abnormalities, and the first thing we required to know was whether it was an acute episode, having excluded hepatitis A and B, or whether it was acute non-A, non-B, or whether it was already chronic non-A, non-B with chronic active hepatitis, which would put the patient at risk of cirrhosis. So the biopsies were done for that diagnostic routine clinical care, but other patients coming through the unit had biopsies, and the randomized part of it was looking at a group of patients from each of a series of designated or diagnosed diseases. So chronic hepatitis B, it was diagnosed serologically to assess what sort of liver disease they have in the prognostic episodes and the prognostic outlook. They would automatically get biopsies or routine biopsies. And similarly, patients with ALT abnormalities attributed to non-A, non-B. The only way of determining what non-A, non-B might be due to was there were studies in the United States and in the London School of Hygiene here in the UK showing that there were certain electron microscopic abnormalities found in patients with one particular type of non-A, non-B, which subsequently turned out to be hepatitis C. And so what we wanted to do is to take biopsies with hepatitis, where we knew the diagnosis, which was hepatitis B, and then take a similar number of biopsies which had been done for routine care reasons, and look at them all under the electron microscope, really, to see how many had these changes, which, at least in animals, in chimpanzees, had been shown in the literature to be due to non-A, non-B. It was a way, if you like, of showing whether this was one disease or several diseases, and really trying to get, at least on one basis, a diagnosis. So that's why it was done, and it turned out that these electron microscopic changes, intranuclear particles, and changes in the parts of the cell where proteins are made, called the endoplasmic reticulum, these were similarly present in human patients as they were in the animal studies, the chimpanzees, mainly from NIH in the United States, but some done here in the UK in the London School of Hygiene. So it was really to see if we could get a histological basis for saying, well, this group have a type of non-A, non-B, and at that stage, the people in the United States said that there was two types of non-A, non-B, one with a short incubation and one with a long incubation. So to get some other basis for separating out the two, long and short incubation, we needed another marker. So this was a study really to look at that issue. And then it turned out that these studies suggested it was a fairly uniform disease in most non-A, non-B.
And if we just look at the next page, and this relates to the specific patients group of those with non-A, non-B hepatitis, picking it up in the first main paragraph, so the second line on the page, 8 haemophiliac and 4 non-haemophiliac patients underwent liver biopsies at between 6 and 36 months after either an episode of acute non-A, non-B hepatitis, 7, or the first detection of abnormal liver function tests, 5. And then we can see the results there. 4 of the haemophiliac patients demonstrated chronic active hepatitis and 4 chronic persistent hepatitis. So I appreciate the numbers are relatively small, as with all of these biopsy studies, but you've got 50% with chronic active hepatitis there. And then of the 4 non-haemophiliac patients, 1 had chronic active hepatitis with cirrhosis, 1 chronic active hepatitis without cirrhosis, so again 50% of those 4 with chronic active hepatitis, and then 2 had chronic lobular hepatitis. Just so that we don't get confused about terminology, is chronic lobular hepatitis to be equated with chronic persistent hepatitis, or is it something else?
No, it's a third condition, and it means that inflammation is distributed throughout the liver lobules. So the whole liver is full of cells. And you can't tell acute hepatitis, acute lobular hepatitis, from chronic lobular hepatitis, apart from by knowing the temporal history. In other words, how long the patient has had an elevated transaminase, which would indicate that that if at some stage during that chronic elevation of the transaminases, there's been a biopsy and you see a lobular hepatitis, then that's chronic. If the patient has had abnormal LFTs for, let's say, 2-3 months, and you see a lobular hepatitis, in that time frame, you would say it's probably acute hepatitis. But until you follow that patient, you won't know, because if he goes on to have abnormalities for 6 months, that lobular hepatitis seen in the first 2 to 3 months is presumed to continue and represents a chronic lobular hepatitis. So chronic lobular hepatitis isn't that helpful in determining who's going to go on to cirrhosis. It's a group really where you need to integrate that biopsy with the temporal sequence of what's been happening to the liver function tests. So, have I explained that all right?
Yes, thank you. And so in relation to this group of 8 patients, the biopsies showed 50% of them with chronic active hepatitis. Is that correct?
Yes.
And then I think we can see from the next paragraph that of those who were within the haemophiliac group, of the 8 patients, 1 had received only cryoprecipitate, but 7 at factor 8 concentrated and mainly commercial source. I then want to ask you about 2 studies that you have referred to in your report to the Penrose inquiry, and I'll do it. I'm not going to ask you any detail about the evidence you gave to Penrose, but rather than look at the underlying studies, it's probably quicker just to go to your report and take it from there. So it's PRSE 304640. And if we go to page 9, please. This is under a heading, the changing perception of severity of non-A, non-B hepatitis. Just pick it up, I think in the last 8 or 9 lines. Actually, I'll pick it up with a sentence that begins, it's about 10 lines down. Thus, in the early days, the liver disease was thought to be relatively mild compared to that seen with HBV, for instance. This view started to change on the basis of the accumulating data from liver biopsies. And then there's a reference there to Dame Sheila Sherlock's book, which you've already referred to. And then we see 2 studies that then set out. One is a study of which you're a co-author, Bamber, Sherlock, Shoah and Thomas, 1981, Journal of Clinical Pathology, Clinical and Histological Features of a Group of Patients with Sporadic Non-A, Non-B Hepatitis. Now, we've got that if we need to look at it, but I think we can take it from here. You record that study as showing that biopsies from patients with chronic non-A, non-B hepatitis covered the whole spectrum of acute and chronic hepatitis, and 1 patient had cirrhosis. And then you referred to a US study entitled Non-A, Non-B Post-Transfusion Hepatitis Disaster After Decades. If we just go over the page. Top of the page, we can see that's a 1982 publication. You say also reflected this changing view and pointed out that non-A, non-B hepatitis was a silent and slowly progressive disease, which ultimately did result in cirrhosis in a proportion of cases. Now, as I say, without going to the detail of those 2 papers, is it fair to say that what you were reporting and what was reported in the American publication in 81 and 82 respectively is essentially consistent with the message you'd given at the symposium in 1980, and indeed the work from Sheffield and Professor Preston published in 1978?
Yes, we were all in accord, really.
Thank you. We can put that away. I'm next going to ask you just about a handful of the various working groups and committees that you were involved with in the late 70s and early 80s. The first is the advisory group on testing for the presence of hepatitis B surface antigen. If we could go to CBLA 40931. So we can see, if we look at the top of the page, this is note of the second meeting of the reconvened advisory group on testing for the presence of hepatitis B surface antigen and its antibody. And the meeting 2nd of April 1979. A number of people listed as present, and you're there for Professor Dame Sheila Sherlock. And then if we can go to the third page, and we just pick up the heading, the top half of the page, non-A, non-B hepatitis. We can see that, as it says this, as previously reported, the department was anxious to encourage research directed towards establishing the extent of the problem in the UK and the development of tests for the agents of non-A, non-B hepatitis. And then there's reference to the Medical Research Council's interest in relation to that. Next paragraph, Dr. Dane proposed that clinicians should be reminded of the importance of reporting all cases of post-transfusion hepatitis, including those which were hepatitis B negative. Then there's reference to studies that Professor Zuckerman wants to undertake. And then if we look at the penultimate paragraph in this section, Dr. van der Velde, Mrs. Supran, said that the arrangements for the notification of post-transfusion jaundice cases were deficient. As anicteric individuals do develop chronic liver disease, these cases would be missed using the present system. It was thought that there was a need to alert RTD, so regional transfusion directors, and hospital staff to the possibility of non-A, non-B hepatitis, and urge notification and reporting of suspect cases. Sample materials being sent to Professor Zuckerman. Disseminating this information could be via medical journals, e.g. the BMJ and Lancet. This should be brought to the attention of regional transfusion directors at their next meeting. So it would appear from this, Professor Thomas, that both the Department of Health and the specific attendees at this meeting were particularly concerned by this time, April 1979, about the non-A, non-B hepatitis, and keen to ensure that there was a proper notification of non-A, non-B hepatitis cases. Is that a correct understanding of what we see here?
Yes. Just to briefly restate it, the only way we could record post-transfusion hepatitis before was jaundice screening. In other words, which is really the extreme end. So if the patient went yellow after blood transfusion, then you knew they'd had post-transfusion hepatitis. But of course, we know that most cases of non-A, non-B hepatitis are anicteric. They don't cause jaundice. And those cases wouldn't be picked up by this post-transfusion jaundice screening. And therefore, we were only looking in the public health screening sense at post-transfusion hepatitis with a very insensitive test. And if you used AST or ALT screening, these are the enzymes you'll recall that indicate liver damage. If you look at these after a blood transfusion, as happened in the United States, then you'd get many more cases. And this is one of the reasons why we thought there were very few cases in the UK, and that the blood in the United States was much more contaminated. It turned out there is a difference, but it's not as big as those original data suggested.
And then if we go to just one further meeting of this particular advisory group, it's at CBLA 301020. And we go to the second page. We look at the top of the page. This is the third meeting of the reconvened advisory group. The date's the 1st of November 1979. Again, you're there deputising for Professor Dame Sheila Sherlock. And if we could go to the next page, please, Seamus, the bottom half of the page. We can see there under the heading non-A, non-B hepatitis. The first paragraph is an update from Professor Zuckerman about the Medical Research Council Working Party. And then the second paragraph says this: it was agreed that Professor Zuckerman, in consultation with Dr. Dane and Professor Dame Sheila Sherlock, should write to the medical press, e.g. the Lancet, to draw attention to the possibility of non-A, non-B hepatitis, and to ask clinicians to provide serum samples to blood transfusion directors with details of cases of hepatitis occurring after the administration of blood and blood products, including factor VIII, and which had been shown to be hepatitis B antigen negative. And then if we go to the last paragraph there, it was agreed that all cases would be notified to the PHLS, so the Public Health Laboratory Service, as well. So again, it would appear that there's a concern here to enhance medical awareness of non-A, non-B hepatitis, and to set in train a system of all cases, not simply those picked up through the identification of jaundice, to the Public Health Laboratory Service. Is that correct?
That is correct, yes.
Now, you were also, I think, a member at this time of the UKHCDO's Hepatitis Working Party, but I'm not going to ask you any specific questions relating to your attendance at those meetings. But could we next go to a third working party, the Working Party on Post-Transfusion Hepatitis? That's NHBT 5068_049. So we can see, if we look at the top of the page, Blood Transfusion Research Committee Working Party on Post-Transfusion Hepatitis, minutes of the second meeting held on June the 25th, 1981. We can see, again, a number of attendees, including you, again, representing Dame Sheila Sherlock. If we go to the third page, just picking it up in the third paragraph, it says, Dr. Howard Thomas said that efforts had been made at the Royal Free Hospital to develop a radioimmunoassay test for non-A, non-B hepatitis using radio-labelled convalescent sera from haemophiliacs, and then further details given, and it says further work was needed with this test. Can you assist us with what the efforts were that were being made, that you were involved with, to develop an RIA test for non-A, non-B hepatitis?
Yes, I did publish that data. It was from a Chinese guy who was a research fellow, and he was very diligent, and what he wanted to do was to try and develop an assay. And my laboratory ran all the hepatitis B surface antigen testing and the hepatitis A testing. So after we'd done those tests, which were necessary to designate hepatitis as non-A, non-B. You'd have to exclude the serological involvement of those cases. Then we kept that serum for maybe 6 months or up to 2 years, depending on how the freezers would accommodate it. And we divided them up into anonymized groups. So there would be one saying normal laboratory personnel, which was my own and all our staff, one hepatitis B, one hepatitis A, one non-A, non-B, alcohol, fatty liver, autoimmune chronic hepatitis, all the different groups, and renal unit and the haemophilia unit. And if we could develop the test, then the only way we could tell whether it might be related to a virus causing non-A, non-B would be by showing that it's more common in the groups where we knew clinically there was a lot of non-A, non-B, which would be the haemophilia unit and the renal unit, but hopefully none in the laboratory staff, including myself. So what my Chinese research fellow did, he took 0.5 milliliter of serum from one of these specimens where there had been a transaminase elevation. He produced, he prepared an immunoglobulin from it, which is the antibody containing a fraction of blood. And then he used that antibody to coat microtiter wells. And then he took another specimen and produced the globulin from it and radio-labeled that in the hope that he would then have what's called a sandwich immunoassay. And he then went to the haemophilia patients. The antibody from one of the specimens was stuck to the microtiter plate. If you put a serum in that contains the antigen to which that antibody was reactive, and then you put on the radio-labeled antibody from another patient's residual serum, then you would see a signal. In other words, there would be binding of the radio-label. And this he then applied to, I think, 50 or so cases from the haemophilia unit, 50 from the renal unit, 50 from my lab staff, 50 alcoholics, in the hope that he might be able to, he might see a higher prevalence of the antigen in the groups that we knew developed non-A, non-B, and that would be the haemophilia patients. Renal unit also had a high proportion, but we hoped not to see it in hepatitis A and hepatitis B or in alcoholics, nor indeed in the laboratory staff populations. And this he found. He found that this antigen, which was being detected by these antibodies, was present in anonymized serum from these various groups. And then we wrote that up in, I've forgotten the publication, but you have got it, and which showed that, yes, there was an antigen in the patients that from the haemophilia unit and the renal unit, but not in alcohol or hepatitis A or hepatitis B cases. And we thought, well, this could be then a component of the non-A, non-B virus, which turned out that it wasn't actually. It was an anti-globulin, but that's why the experiments were done. The experiments, as I say, were done with serum that was left after we had tested for hepatitis A and B, which was part of the diagnostic service that my laboratory provided in diagnosing non-A, non-B, excluding hepatitis A and hepatitis B. So we kept the residual serum from those cases, which was usually about 0.5 to 1 milliliter of serum, in the hope that they would be of use in the future, and we would throw them out after six months when the freezer. We had 2 freezers when those freezers became full. So that's what that study was about, and I think it was Dr. Luo, L-U-O, I think, of which you have his paper that was, and I alluded to that assay in the Glasgow meeting.
The documents from the early 80s also refer to you undertaking work with Dr. Janissy on diagnostic tests and working with Dr. Dane on a radio immunoassay test for non-A, non-B hepatitis. Are those all separate pieces of work? No,
they were all, because I was developing new assays and trying to find non-A, non-B. I had a collaboration going with Dr. Janissy in which we would try to produce mouse monoclonal antibodies to the components of hepatitis A and hepatitis B, so that we might improve on the existing assays which Abbott produced and which involved sheep antiserum produced by inoculating a sheep with, let's say, hepatitis B surface antigen. So in order to make that reproducible, monoclonal antibody technology had been developed by Cesar Milstein. And I had shown an interest in that, as had George Janissy, as the professor of immunology. So I purified viral antigens, in particular hepatitis B surface antigen and hepatitis B core. We immunized mice with those antigens and produced monoclonal antibodies, which are pure antibodies do you understand? I'm sorry, not being rude, but do you understand the monoclonal antibody term?
Well, in fact, one of the questions I've been asked by core participants to ask you, which was what was going to be my next question, is if you could tell us what you mean by monoclonal antibodies.
Well, what Mr. Milstein showed with Greg Winters, who was at Imperial, and Alan Fursch, if you immunize a mouse with, let's say, hepatitis B surface antigen, then that mouse will produce a heap of antibodies to different parts of the viral protein. So there might be 100 or 200 different antibodies, all binding to different parts of the viral antigen. So you immunized a mouse with the antigen, and then you took the spleen cells from that immune mouse and you fused them with a myeloma cell, which is a malignant antibody-producing cell. And then the progeny from that fusion, so-called hybrids, would have the joint function of, or the joint property of being malignant, so they were kept on producing the antibody, and each hybrid would produce a different single antibody because we cloned them out. So a monoclonal antibody is a malignant cell line producing pure, 100% pure antibody to a particular epitope. An epitope is just a part of an antigen. Remember, I just said that an antigen might have 100 or more epitopes, fragments of the antigen to which the antibodies bind. And those antibodies are very useful to produce radioimmunoassays or enzyme immunoassays. And I developed some with funding from NRDC, I think it was called then, but then became British Technology Group. And George Gianossi and I were funded for a lot of money to produce these antibodies, which would be a leap forward in diagnostic antibody test, diagnostic hepatitis testing. And luckily we were successful in doing that. We were using that assay, the monoclonal antibody tested assay, as well as the commercial antibody assay for testing for hepatitis B surface antigen. And we found that the monoclonal antibody-based assay was much more sensitive. We got positives in specimens that were otherwise negative by the commercial Abbott assay for hepatitis B surface antigen. And at that stage, we wondered whether those extra ones were a sort of spin-off of hepatitis B, which the French and a group in America had suggested, that we were picking up with our monoclonal antibodies. And this monoclonal antibody assay for hepatitis B surface antigen might be picking up a non-A, non-B assay. Turned out that wasn't the case, but the assay was subsequently commercialized by a variety of companies who paid royalties to the Royal Free and a proportion of a royalty to George Gianossi and myself and another lady who'd helped. So that's the basis of that story.
You say in your, we can take the document down, thank you. You say in your witness statement that you offered to provide monoclonal antibodies to Dr. McClelland for the purpose of a study. You weren't sure whether that offer was taken up, I think, from what
right.
the statement suggests. But what was the purpose of the offer to Dr. McClelland?
Well, as well as producing antibodies to hepatitis B surface antigen, which is the envelope of hepatitis B, we also produced antibodies to what is called the core, the center of the hepatitis B virus. And we then were able to, it doesn't matter the detail, but we could use that monoclonal antibody to produce a very sensitive and reproducible assay to measure antibody to hepatitis B core. And everybody who's infected either acutely or chronically, and the acute ones that get better, all of this group will have antibody to hepatitis B core. Okay, so it was a good indication of infection, acute or chronic, cured or persistent, self-cured or persistent, for hepatitis B. And that the Americans and the Germans had used what they call surrogate tests to try and detect high-risk donors transmitting non-A, non-B. And they were wanting to do, and the Americans had done this, as did the Germans, and it effectively picked up some cases of non-A, non-B. It was called a surrogate test, and before we had the discovery of the hepatitis C virus, the Americans and the Germans decided they would use these surrogates, an ALT screen and an anti-core screen, to pick up these non-A, non-Bs. We had a meeting, I don't know which committee it was, but it was discussion of whether we could use them in the United Kingdom, really. The blood transfusion service were a little bit against it, because they said they would pick up a lot of people, particularly with the ALT part of that combination, a large number of people with alcohol-related liver disease or type 2 diabetes, fatty liver, which would be true. And therefore, before we could determine how useful that ALT screen and with the anti-core screen, and I should add at this stage that anti-core picked up people with a lifestyle which was deemed to be high risk. So a lot of intravenous drug users had antibody to hepatitis B core, as did people with a lot of sexual partners. They might have antibody to core as well. And you probably know that the blood transfusion service in the UK had been interviewing patients prior to accepting them as donors to try and identify whether they had a high-risk lifestyle, for want of a better term. Had they used drugs? Were they promiscuous? And so this surrogate of an ALT and an anti-core was being evaluated. And the BTS, the Blood Transfusion Service in the UK, thought that we were going to get a lot of false positives. And Dr. McLennan, so that they wouldn't introduce it, on the basis of what had been done in America and Germany, they wanted to see what the yield of infected material by preventing non-A, non-B post-transfusion hepatitis would occur in the UK. And then the cost of that came up, and the Department of, I think it was Dr. Metters, who was the medical officer in the Department of Health at that stage, said, well, if we did a trial, how much would that cost? In other words, screening everybody and looking how many would be taken out. And that, when we worked it through, was going to be very expensive. So I said, well, monoclonal antibodies cost me nothing. I mean, one mouse produces enough antibodies probably for 1 million tests. So I said that he could have that monoclonal antibody assay in Edinburgh if he was willing to do the test. And I gave him the telephone number of Peter Karianis, who was an academic colleague in the department, asking Brian McLennan to bring him if he wanted to take up that offer. And Peter would have sent him the antibody. But I think for some reason or other, it didn't happen.
And you said in the statement that your view was that anti-HBC and ALT surrogate non-A, non-B screening of blood donations should have been introduced. Is that correct?
Yeah, I thought it was. We should have introduced it, but at least we should, having heard the counter argument, which we were going to get a lot of false positives, which is reasonable, and I took that on board. I thought that it would be reasonable then to do a trial to see how many units we lost and whether we did reduce the incidence of post-transfusion non-A, non-B. And then we could work on a much better basis. And that's why if we could reduce the cost with free anti-core, which was the expensive component of that trial, then it might make it more plausible, or possible rather, not plausible.
And then can I then just turn to the question of screening for hepatitis C once an antibody assay was available. And I'm going to direct your attention to an article you wrote with a colleague, Dr. Brown. It's NHBT 0088770. So we can see this is published in Medical Virology. It's entitled Blood Transfusion Services Should Have Begun Screening for Hepatitis C when an antibody assay first became available. So in favour of that proposition, Dr. Brown and you, and then against Dr. Barbara from the Colindale Blood Transfusion Centre. And then if we can just look at the bottom half of the page. I want to pick up in the left-hand column, in the 3 paragraphs up from the bottom, it says, in the early 1980s, it was shown that the incidence of non-A, non-B hepatitis could be almost halved by the exclusion of donors with antibodies to hepatitis B core or abnormal liver function tests. And that, I think, is the issue you were addressing a few minutes ago. And then the presence of these surrogate markers for non-A, non-B hepatitis resulted in a loss of only 4% of the donors. Then you refer to the identification in 1989 of the hepatitis C virus. And then you say at the bottom of the page, in this paper, the argument for blood transfusion services should have begun screening for hepatitis C when we go to the top of the next column, antibody assay first became available, will be developed by examining what's known about the serology of hepatitis C to determine how many donations will be excluded by screening for anti-C100, how many cases of post-transfusion hepatitis could be avoided by eliminating blood products positive for anti-C100, and how many cases of post-transfusion hepatitis would not be prevented by such a screening programme. I'm not going to go through the detail of the arguments, but we just pick up with your conclusion, bottom of the next page. Under the heading conclusion, very bottom of the page, the introduction of an HCV screening programme for blood products using the anti-C100 assay would cost about £6 to £25 million per year, would result in the loss of, top of the next page, 12,500 to 25,000 donations per year, and prevent between 2,500 and 5,000 cases of post-transfusion hepatitis per year. Between 1,250 and 2,500 cases of chronic liver disease per year, and 250 to 500 cases of cirrhosis per year could be prevented. But a similar number of cases would still occur because of the 50% sensitivity of the test. And then you go on to say patients with CLD, chronic liver disease, will consume NHS resources as they develop the complications of portal hypertension. The cost of 250 liver transplants is about 8.75 million. It would seem to us, therefore, that there are financial as well as ethical considerations in HCV screening. Clinicians tend to underestimate the magnitude of the problem, as 75% of PTH cases are anicteric. If we're not doing everything possible to prevent non-A, non-B post-transfusion hepatitis, we may find ourselves in a difficult situation when the first group of cirrhotics in the anti-C100 era become litigious. And then we have Dr. Barbara's counter-argument in the rest of the article. I think you said in your statement, Professor Thomas, you don't have really anything to add to that, but it's a perspective that we've not yet explored, and I wanted to ask whether, in addition to publishing this article, whether you were involved in any meetings or discussions with the Department of Health or Blood Transfusion Service as to whether this screening should have been introduced.
Well, it was my view that we should introduce it. I should say in the context of this article that I guess the editor of this journal was Professor Paul Griffith, who was the professor of virology at the Royal Free. And he'd just set up this journal, and he was looking for someone to write in favour of this, as opposed to a member of the blood transfusion service who he knew would be able to write against it. It was almost, as I said, I think at Penrose inquiry, that this is the sort of this was a sort of adversarial format, or not an adversarial format, but where, a bit like barristers, one would present one case, one aspect of an argument, I suppose the defence, and then another would produce the defence, and then I, because I was a physician, and physicians in the main are interested in individual patients, whereas the blood transfusion service and epidemiologists are much more concerned with populations of patients and economic issues. So I thought it would be useful for Jonathan Brown to work this through. He was a registrar in my department. So I asked him to do this. We sat down and talked about how we might do it. And that's how it came about. I can't there was this discussion, not only about ALT and anti-core screening, as I alluded to, which was in the context of blood transfusion, but there were discussions also on, which I think I was present at, looking at, whether we should go with the stage 1 or the first available assay for anti-core, or whether we should wait for the second format, which was likely to be ready in a year and would get rid of a lot of the false positives. So in answer to your question, this is how I felt about it. I thought it would be useful to work it through economically, because that would give solid facts. But there is an ethical issue as well. Dr. Barber genuinely thought that they would be losing large numbers of units of blood, and they wouldn't be able to supply enough blood because of all the false positive blood would be lost. And I could see that argument as well. And we're both friends, and we said, well, let's do the best and write the arguments for and against. And that's what we did. It must be taken up subsequently, but I didn't hear any more about it, as to whether it had been introduced or not at the time, until it came through and it turned out it hadn't been introduced, and that we were going to wait until, I think, 1991, September, for the second generation assay, which had got rid of a lot of the false positives, which was more acceptable to the blood transfusion service because they would lose a smaller number of units of blood. And it's a proper concern, isn't it? That if you're involved in a road traffic accident or you're going to have cardiac surgery, you will expect the blood transfusion service to provide enough blood for you to go through that quite safely. So he presented the argument for that, and I presented the argument for the number of patients who might die by not using the first generation assay. So that's the situation. And clearly, then it went internal into the health service, into the health service, and someone somewhere decided that they wouldn't introduce it.
The next, and for present purposes at least, the last lot of questions I have for you, Professor Thomas, relate to a study which Dr. Karnoff was involved with and in which you were involved. If I can pick it up in your witness statement, at WITN 3824007, if we can go to, can we try page 10, Seamus? Mine's in a slightly different format. Yes. So if we pick it up at the top of the page, you say that you refer there to a prospective study of 30 patients recording the incidence of abnormal LFTs and persistent abnormalities after infusion of cryoprecipitate, NHS factor 8 and 9 or USA factor 8 concentrate. And then you refer in brackets to the article itself, high risk of non-A, non-B after first exposure to volunteer or commercial factor 8. We'll look at that in a moment. And then you say this was done, so the study was done because abnormal liver tests had already been reported in the USA, and it was important to know in each case whether the abnormality had been there before treatment, in which case it would not be due to post-transfusion non-A, non-B hepatitis. And then you refer a little further down to the study being supervised by the haemophilia unit and to Professor Kernoff stating in the paper it was approved by the ethics committee and all patients giving verbal consent. And you say your contribution as a hepatologist was to provide advice on management of liver abnormalities. I'm going to ask you to look at the paper, and I've got some questions I've been asked to ask you. I don't know whether you're going to be able to assist with casting further light on this, but you'll appreciate they're not questions I can pose to Dr. Kernoff. So if we go to PRSE 303439. So this is the paper you've referred to in your witness statement. High risk of non-A, non-B hepatitis after first exposure to volunteer or commercial clotting factor concentrates. And then we can see the authors there, Kernoff, Lee, Karayanis, and you. And then we see the summary. After first exposure to factor 8 concentrates, 9 out of 9 British patients treated with USA-derived commercial products and 10 out of 12 treated with British volunteer NHS products developed acute non-A, non-B hepatitis. Hepatitis following commercial products was more severe and of shorter incubation, etc. Now, are you... I don't know whether you, as I say, you can assist with this, but if, as your witness statement suggests, this study was undertaken because of concern over reports of abnormal liver function tests from the USA, what was the justification for Royal Free Hospital patients being moved from cryoprecipitate to factor concentrates?
Well, I think the context of this was that, all the patients that went into this study had come into the haemophilia unit at the Royal Free, either with a bleeding episode or latterly, I'm not sure whether the second group I'm going to mention were involved here, or latterly, whether when factor 8 concentrates were used prophylactically. In other words, the haemophilia population found the concentrates very patient-friendly, if I call it to patient, because we didn't know about any of the problems that were being transmitted. But, if you had a painful hemarthrosis bleeding into your joint, which your doctors would tell you would cause fibrosis and deformities, then an injection of this material stopped that. And very soon after, it was a natural extension of this to ask, well, if we took this, I think it was 3 times a week, would it prevent having hemarthroses and muscle bleeds and things? So these young, in the main boys, in the first few years of life, could then actually play and develop normally as normal children. So the use of these concentrates at this stage was very very important. People wanted to have them. I think what shouldn't have happened, and the haemophilia directors, of which Peter Kernoff was one, had argued that only if you had severe haemophilia with virtually I'm not a haemophilia doctor, but virtually a total deficiency of the factor 8 in your blood, would you need these concentrates? If you had mild haemophilia, you could be treated with cryoprecipitate, which was derived just from 8 units of blood. And already it was known that the risk of getting non-A, non-B hepatitis after cryoprecipitate use was much less than if you use concentrates. So, and there was an agreement with the haemophilia directors that, what the cutoff would be, which patients would get vasopressin, which released any remaining factor VIII globulins from the patient's liver cells, or could be treated with cryoprecipitate rather than the higher risk concentrates. But and of the group who had the more severe haemophilia, when they came in with a bleeding episode, they would be, in the middle of the night often, they would be given concentrate. And I think what Peter Kernoff decided to do, with the agreement of the ethics committee and the consent of the patients, randomly allocate them to whether they received NHS or commercial material. And they were also following transaminases at this time to see whether patients did get ALT abnormalities. Essentially, virtually 100%, whether it was an NHS concentrate or a commercial concentrate, got abnormalities. And that was predictable in a way because the incidence of hepatitis non-A, non-B was something like 0.5% in British donors, and about 2 or 3% in American commercial donors. And since something like 1,500 litres or donations of blood were used for each preparation, every single preparation would be expected to contain the virus. And indeed, this is what turned out to be the case. So what this study showed in patients who should have all had severe factor VIII deficiency, and I don't know whether any of them are there any in the list of patients who had mild disease? Because if there were, then those people shouldn't have had the concentrates. They should have had the cryoprecipitate. And I think the intention was it should have only been those patients who could only be treated with the cryoprecipitate, with the concentrate, who would have been included in this study. I think the protocol would have said, I presume, that anybody with mild disease should not be included because they should be getting cryoprecipitate, and indeed the majority would have been. So I think that's the background to it, and afterwards, when it turned out, Professor Kernoff found that virtually everybody developed abnormal transaminases after use of these concentrates. He then wanted to ask the question of, was there an antibody out there in people who had had concentrates in the past and had normal transaminases, indicating that they possibly had recovered from a non-A, non-B infection. If you used a globulin from their blood, an antibody-containing globulin, and gave it with the concentrates, where he knew that there would be 100% incidence of non-A, non-B, if you gave this antibody, could you prevent it happening? And again, he explained that to the patients. There was, I think, 1 or 2 cases where it looks as if the immune serum globulin, as it was called, prevented factor IX deficient patients receiving factor IX concentrates from developing hepatitis. But it was 1 patient, it says here, just 1 patient appeared to be protected, which wouldn't be statistically significant, but did suggest that there might be something called protective immunity that might be useful in this context, severe haemophiliacs receiving concentrates where they're all getting ALT abnormalities. I think that's the background of it in the main.
You said, Professor Thomas, that Dr. Kernoff discussed matters with the patients and consent was given. Do you have any first-hand knowledge yourself of what was said to the patients who were participating in this study?
No, but I mean, Peter Kernoff was an obsessive individual. I mean, he ran the unit with a rod of iron, and the reason occasional patients may have got concentrate when they should have had cryo, in other words, mild haemophiliacs, was related to the fact that he would set up the rules, and the patients who came in the middle of the night would be looked after by a registrar or a haemophilia nurse who would be in the middle of the night looking for the concentrate in a freezer. And the other thing that Peter tried to do was make sure that any one patient, if they had repeated episodes of either bleeding or were having the factor VIII concentrate prophylactically, in other words, to try and prevent bleeding episodes, that patient's material was all kept aside from one manufacturer, whether it was a British or an American, so that they all got the same, that individual would always get the same batch, which would, he thought, reduce, if anything, the chance of them being affected. So Peter organized it extremely well. And Christine Lee took over as the head of the unit, the clinical unit. Professor Ted Tuddenham mainly did research, but Christine, I think, was the head of the clinical service. And I think you've interviewed her, really. My role came in when, if they had developed abnormal transaminases, what it might be due to. And that is when there was a discussion as to what we should do, because we had done a trial in patients with non-A, non-B outside the haemophilia population and showed that interferon normalized their liver test abnormalities. And we wanted to discuss, in the context of a joint clinic where we had a registrar from the liver unit and a registrar from the haemophilia unit, plus or minus consultants in both those units, seeing all the cases in the haemophilia unit that had abnormal liver tests. And at these clinics, that's where there would have been discussions on behalf of the liver unit as to what might be done. And we decided we would try to, having published in the BMJ the demonstration that liver tests became normal in non-haemophiliac patients with non-A, non-B when treated with interferon, that we would try it in the haemophilia population. And it was a separate issue because, of course, because of the bleeding problems with a haemophiliac, we would have to give it probably not intramuscularly, but intravenously, and with cover of a coagulation factor, which would involve giving more of one of the concentrates, which is why I know that Peter Kernoff would be very keen to make sure that there would be a batch from one manufacturer which had a patient's name on it, which would only be kept for that patient, for instance, so they always got the same material. Because one of the things he was concerned about, if we went into this trial, would be, since they would have to give concentrates, which this study had shown were transmitting non-A, non-B, he wanted to make sure that he wasn't giving them a second episode, because we thought there may be two viruses at that stage. So he used the same batch. So that was the background to all of that. And the trial was successful in the non-haemophiliac patients, and that was published in the British Medical Journal.
Just sticking with the study that we see here, as a hepatologist involved with this study, was it your expectation that the patients who were being enrolled in it and participating in it should have been advised of the risks of developing non-A, non-B hepatitis from the factor concentrates with which they were going to be treated?
Yeah, I mean, these patients were drawn from the haemophilia clinics, and I think Peter and Christine say that they were asked for informed consent, and the ethics committee of the Royal Free were asked to comment on it. Does it not say that in that text?
It says that they were asked to give consent, but doesn't provide full details of what that consent process would have entailed. So my question is really, as a matter of principle, would you expect the information given to patients who are being asked to participate in this study to have included an explanation of the high probability, if not near certainty, of developing non-A, non-B hepatitis?
Yes, I think you would have had to, say that there are two preparations, and you need to have one. We don't know which is the better one, although you might argue, I suppose, that there was a suspicion, although it turned out to be wrong, that the American one was going to be more of a problem. But I think it's worthwhile saying here that although because of the background information that was around, which was there was a paper from Oliver James, for instance, showing that after cardiac surgery in Newcastle, the incidence of non-A, non-B after use of Brad was very low, whereas after cardiac surgery in the United States, it was very high. But there was a feeling that even if it was low, as in the Newcastle study, I think he said it was about 0.2%. Each patient for cardiac work would have about 6 or 8 units of blood, so the total risk would be about 1.5% getting an ALT elevation after transfusion, whereas the American incidence was about 2 or 3 times that. But we weren't. The concentrates were being made from 1,500 units of blood. So even accepting the very low incidence of infected blood in the UK as on the basis of the Newcastle Oliver James study, every pint, every unit of factor VIII concentrate would contain the virus. And indeed, that turned out to be the case. So I think they had reason to believe that hepatitis C was going to be the same after a volunteer UK or American. But what was not going to be the same was the HIV incidence, because patients had not yet been described, as far as I can recall, in the UK, whereas in California and in the American system, HIV had already been described. So there was going to be, I thought anyway, no difference in the prevalence of hepatitis C, non-A, non-B, with these two concentrates. But HIV, I think probably, with the benefit of hindsight, might have been shown to be different because they'd already seen it in the US and we were still looking for it in the UK.
Just two further questions.
That's quite a complicated issue, really. And
yes, and I'm not going to be asking you about HIV. Just two further questions in relation to this study. Do you recall how soon after the commencement of the study you began to receive abnormal liver function test results?
You mean after this?
In the course of this study,
yes.
How soon after the study commenced were abnormal liver function test results being reported to you? Are you able to recall?
I can't recall really, because as I say, I was involved in the, in looking at how we would manage these patients afterwards, and what the significance would be, and also what we would need to do to find out what the cause of the abnormal ALT was, because at that stage there were at least 3 hypotheses. One was that it was a virus. The second was that it was due to chemicals which are used in the preparation of the concentrates for preservatives and what have you. And the third was that it might be related to immunization against HLA proteins, human leukocyte or transplantation antigens, which can cause immunosuppression, which was relevant because the other thing that was of concern was whether HIV was being seen in British patients at that stage. And I think there were a lot of reasons why the patients with haemophilia might be immunosuppressed. One of which was just there was a lot of materials other than factor VIII in the concentrates. HLA proteins, beta-2 microglobulin were 2, which could depress the immune system. So my contribution was to think of a battery of tests which we would apply to each person when their ALT was known or first seen to be abnormal, to find out what it might be. It might have been due to hepatitis B, for instance, because there were some concentrates which were transmitting hepatitis B, for instance.
As it became,
sorry. That was my role, to look at what was happening and why the patients had got abnormal ALTs.
As it became apparent that the patients enrolled in this study were developing post-transfusion non-A, non-B hepatitis, was it, in your view, ethical to continue with the study?
Well, luckily I wasn't involved in that situation. Well, I suppose if they were seeing an equal incidence of abnormal transaminase in both groups, and I don't know, was this, I've forgotten now, was this blinded? In other words, did they know which group were getting which product?
I'm afraid I don't know without checking, Professor,
but I
whether
think
that's the case
they
or
must
not.
have, bearing in mind the prevalence, the incidence rather, of abnormal liver tests was the same with all the concentrates. They must have seen abnormal LFTs in all of the patients, after in the follow-up, and in which case, if you're seeing it after, both, and you're giving it for a bleeding episode, it is ethical to continue. The patient must get something, or you're suggesting they might have at that stage switched to cryoprecipitate, or
that's the inference, Professor. Yes, but not least because these are patients who were being exposed to concentrates for the first time, as the study tells us.
Oh, right. Yes.
I was just going to ask about that, because these were all patients who, by definition, presumably, to be entered into the study, had no obvious sign of suffering from non-A, non-B hepatitis.
Well, presumably, did they have ALTs beforehand? I think they did.
Well, if they did, and they were entered knowing that they were suffering from hepatitis, that's one thing. But in that case, one wonders why the study was going to be of any value.
Well, it wouldn't have been of value had they had abnormal ALTs before. Then you wouldn't have been able to determine anything.
So the object of the study is to take people who had not shown any signs of non-A, non-B hepatitis and administer to them a product which it was hypothesized might give them less hepatitis if it was NHS made, and give them a lot more risk of it if it was commercial, on the basis that probably one or the other would provide it. There'd have to be some therapeutic reason for the treatment.
Yes,
how is that anticipated, can you help, in advance of the study actually being conducted, that they were people who, though they had never had concentrate before, were likely to or might need it in the future, so that they could then be studied and asked for their consent to have this product administered to them?
Well, surely I haven't gone back over this recently, and I assume that you would ask Professor Lee about this, but if somebody comes in, these were severe haemophiliacs, I think, where vasopressin, which releases the patient's own factor VIII or cryoprecipitate, were ruled out. So the protocol, I presume, would have said patients coming in with bleeding episodes, in the middle of the night or during the day, would need treatment with one of the concentrates. So they would give one or other of the concentrates to treat the episode.
I think rather than speculate, I have read the study at least a couple of times, but I probably ought to reread it because it'll answer the questions I've just raised.
Yes, and so I was just going to point out, some of the patients, a minority, were virgin haemophiliacs, that rather awful phrase, and most are described as needing infrequent treatment and therefore would, I think, be unlikely to be severe haemophiliacs. That's the bottom of page 2 of the report.
Or severe haemophiliacs who would just happen to be in that rare group that would require very little treatment.
Yeah, yes.
Well, I think, obviously you can't interview Peter Kernoff, but the haemophilia doctors who were taking care of these patients at this time, you can ask about these issues. As I say, my role was to work out why they had become, why they had abnormal liver function tests after these concentrates. And you might say, well, surely it would be obvious, but as I say, and I think in other studies that were published at this time, some patients had hepatitis B and C at the same time. Some had hepatitis B and had Delta virus infection as well. And there are other patients who had other problems. We were trying to, at that stage, also look at patients who had persistent abnormalities to see whether or not they should have, whether they needed a liver biopsy to determine this issue, or whether they had chronic persistent or chronic active hepatitis. In the main, I think this was after we'd already determined that a lot had chronic active hepatitis, so I don't think any of these did have liver biopsies. But you really need to ask the haemophilia unit what was going on. Then I saw them afterwards, after it had happened. But that's all I can say about that at the moment. Unless you want me to read it again, because
I think you've answered very fairly in saying that, in essence, the study was one which was organised by the haemophilia unit, and we have already asked Professor Lee about this general area and about her study. So I think I don't trouble you any further.
So those are the questions I have for Professor Thomas, but we obviously need to give an opportunity to core participants and their legal representatives to suggest any further questions arising out of Professor Thomas's evidence today. So if we could take a break at this stage to enable me to receive and consider any questions. And obviously to give Professor Thomas a break as well.
Yeah, absolutely. Just by way of explanation, Professor, there are quite a number of people who plainly aren't here at the moment. They are also remote who are watching, who are entitled to ask through counsel questions which they have in their minds arising out of what you can say. And counsel will receive and field those questions and ask those that are appropriate to you when we come back, which will be at 4:10.
Okay, well, thank you very much.